Hello class, this short PowerPoint presentation will review assessment of cardiovascular function and go over some very basic hemodynamics. As a new grad and when you are taking your NCLEX, you will be expected to know some basic terminology that is related to hemodynamics, although you would not be expected to manage these functions. If you were working in ICU or a cardiac care unit, you would be trained in doing some of the hemodynamic monitoring. But for this class and for your NCLEX, you do need to know some basic terminology related to hemodynamics. Also, we are going to cover a bit about endotracheal tubes, again, so you're prepared to answer NCLEX questions. And finally, a short, brief discussion of caring for a patient in ICU. So you do need to go back over your textbook and review in your chapter the anatomy and physiology of the heart. I am not going to go through this at this point in time because this should be a review for you, but understand that when you know the function and the pathophysiology, the disease process, and the hemodynamic monitoring will make a difference. So looking at your right atrium, right ventricle, and your left atrium and left ventricle, some of these will come into play when we talk about the monitoring. Again, this is looking at pressures within the heart, and these do come into play when you are doing hemodynamic monitoring. You would not be expected at this level to know all these pressures. But again, if you were working in intensive care, this would be something you would be trained to monitor and understand. There's again a picture of your heart and the electrophysiology. So what we're going to discuss in this PowerPoint are some basic terminology, and what you need to know are some terms such as cardiac output, stroke volume, and stroke and vascular resistance. So basically, stroke volume is the volume of blood ejected during systole. Cardiac output, which is the amount of blood ejected by the heart in 1 minute and is measured by liters, is normally about 5 liters per minute and is determined by multiplying the heart rate by the stroke volume. So heart rate and stroke volume determine cardiac output. And when you look at stroke volume and the amount of blood ejected with each heartbeat, you look at preload, which is the degree of stretch in the cardiac muscles at the end, and diastole, and afterload, the resistance to the ejection of blood from the ventricles. And then contractibility is just looking at the ability of the cardiac muscle to contract or to shorten in response to the electrical impulse. These are terms that you need to know, and if you want more information to understand cardiac output, stroke volume, preload, and afterload, I suggest you go to YouTube video. There's a lot of information on there that make it easy and simple to understand, and it's a good idea to do that. Ejection fracture is the percent of end diastolic volume ejected with each heartbeat. So again, we talked about cardiac output, and I'm going to go over these terms again, is stroke volume times heart rate. There are influencing factors such as the autonomic system. Again, we talked about preload and afterload and contractibility. So when you're doing an assessment of you would be taking health history, the demographics, genetics, culture, risk factors. These would all come into play when caring for a patient who is being taken care of and hemodynamic monitoring is being used. Some of the common forms of hemodynamic monitoring are central venous pressure, pulmonary artery pressure, interarterial blood pressure monitoring, pulmonary artery wedge pressure, which is PAWP. Those are terms you would need to be familiar with. So again, and I can't stress this enough, knowing what cardiac output is. It's the volume of blood pumped by the heart in 1 minute. It is increased cardiac output could be an indication of high circulating volume. So when you run, you would increase your cardiac output. You may have decreased cardiac output, or a decrease in volume would be with like cardiomyopathy, where the heart is not working quite as well. Stroke volume we talked about. An example of stroke volume is maybe an indication of a valve dysfunction resulting in heart failure. An increase in stroke volume, again, may be caused by an increase in circulating volume. So the amount of blood that is circulating through your system. Preload occurs during diastole, and it is a combination of the pulmonary blood filling in the atria. Sorry for the misspelling there. I thought I had changed these two words, and it looks like they did not get changed. And stretching the myocardial fiber. A decrease in the volume may decrease preload, and that could be in dehydration. An increase in volume will increase the preload and would also increase the mean arterial pressure. This is a nice picture that I have taken and cited from Nurse's Memory Notebook. I really think Nurse's Memory Notebook is a great adjunct to your nursing education. It is filled with pictures like this that make understanding easy. So here's a picture of the heart and showing preload going into the ventricles at the end of diastole. Here are the increases in it. Afterload, resistance left by the ventricle must overcome to circulate the blood. Increased in hypertension and vasoconstriction. Systemic vascular resistance is a measurement of the resistance or opposition of systemic vascular bed to blood flow. It can be calculated by using the cardiac output, the mean arterial pressure, and the central venous pressure. And again, if you were working in an intensive care unit, you would need to know this. You should also need to know this equation again for possible NCLEX testing, because central venous pressure is normally near 0 milligrams Hg. Sometimes it is simplified to just MAP divided by cardiac output. This is a picture of understanding pulmonary catheter monitoring, and pulmonary artery pressure monitoring is used in critical care for assessing left ventricular function, diagnosing the reason behind shock, and evaluating the patient's response to medical interventions. I'm not going to go through all the pieces of it. You can look it up in your book. You do have a monitor, a pressure bags to prevent backflow, and this goes into the superior vena cava. Central venous pressure is a little bit less complicated. It is the opposition encountered by the right ventricle or the right ventricle preload. There are problems that can be related to an elevated CVP, such as too much volume, which could be related to right-sided heart failure, in contrast to a low CVP, which could be related to hypovolemia or dehydration, or something that's causing loss of fluid within the body. And the measurement is in, like I said, the vena cava or right atrium. And The normal is usually 2 to 6, and it is measured by putting that catheter in the right atrium or vena cava. When it is inserted, it's done by a physician under sterile. It's a sterile procedure. Once it is put into the patient, an X-ray is taken for proper placement. Again, when a person has central venous pressure monitoring taking place, you definitely need to make sure that the air is free of any air bubbles, because that is going directly into the person's heart. And you need to know about how to measure the central venous pressure. And basically, I'm going to show you a picture of that. The patient needs to be in a flat position, and this is I'm trying to find here we go, the phlebostatic axis. The stopcock and the transducer need to be zeroed out at this point. The patient's bed may be raised up to 60 degrees, but when you're taking that pressure, then you have to zero out the stopcock at any level. There are complications that can occur with hemodynamic monitoring. The more uncommon ones are pneumothorax, because the catheter punctured the lung. Air embolism. The most common one is infection, which is related to bacteria going through the catheter at the insertion site. And that is why when you do a dressing change on a central line, you would always be using a mask for yourself, for the patient, and sterile technique. And this just talks about how catheter-related bloodstream infections are the most common and also the most preventable complication related to central venous pressure monitoring. All right, then we're going to skip over to emergency management of upper airway obstruction. And basically what we're talking about in this situation, you do need to know about caring for a patient who has an endotracheal put in. This is done by usually a nurse anesthetist or an anesthesiologist. This needs to be put into the patient via a scope, and you would check to make sure that the patient has the cuff inflated. So once I'll go back to that picture, there should be this cuff needs to be inflated so that secretions can't get down and into the airway. So that is inflated to prevent that. Then it is important to know with the patient who has an endotracheal tube, when you do suction the patient, you need to review that in your textbook. Again, these are basic NCLEX questions. You would suction a patient when you hear adventitious breath sounds. When you do put if you assist with an endotracheal placement, you would make sure that you hear equal air distribution in both lungs, and you would look for the chest to rise and fall asymmetrically. You would check the cuff pressure every 6 to 8 hours, and many times there's a protocol in the ICU that you would deflate that cuff so that there's not wearing away of the esophagus. What can happen is the person actually can erode, and I have actually worked in intensive care, and it did erode, and the patient did bleed out. So you would be deflating that again, but that would be based on your protocol in your ICU. The patient should have high humidity related to the endotracheal tube placement. These are the references that I used for this PowerPoint. What I did also want to just briefly mention is if you are caring for a client in ICU, you know that many patients experience sleep deprivation, because if you think about it, in ICU, there's really no night and day. These patients are being monitored 24/7. The lights are often on 24/7. They don't get periods of long sleep. So you need to think about as a nurse, how can I help with the person who's in intensive care? What can I do to cluster cares so that they are given time to sleep? The other thing you need to think about is the family. These are critical situations. The family is very concerned. When can the family come in? Informing the family, patient teaching, keeping the whole staff, interprofessional staff informed, including the family and the patient. So that ends this brief PowerPoint. Please review your chapters before you take the test. There will be questions on this material and from your book, and then also the PowerPoint on dialysis, which is further down.